I'm David Brenner, the Vice Chancellor for Health Sciences. I want to welcome you this afternoon. The title of our health talk today is Trusting Your Gut. Our program will consist of first a discussion by a panel of experts, then there'll be a live question and answer that will be fielded by me but answered by our experts. This is a particularly great topic for me because I'm a gastroenterologist, but also because this year, the U.S. News and World Report recognized UC San Diego as the #1 center, #1 university and program in the world in gastroenterology and hepatology. We have some of the world's leading experts. They're conducting breakthrough research that is leading to new and innovative care for diseases of the gastrointestinal tract. So today I'm honored to welcome some of the brightest minds in the field. These are Dr. Rena Yadlapati, who is the director of the Center for Esophageal Disease, Dr. Bernd Schnabl, who is director of the San Diego Digestive Disease Research Center, an NIH-funded center, and Dr. Parambir Dulai, who is the assistant professor in Division of Gastroenterology. But first, I'm going to introduce my friend and colleague, Dr. Tom Savides. He is a leader across this entire campus, and he has agreed once more to be our interim chief for the Division of Gastroenterology and Hepatology. But he has many other jobs. He's also the chief experience officer at UC San Diego Health. He is our expert on how to improve the healthcare experience of our patients and their families. He has volunteered to I think it's his third time to be interim chief, while our colleague, Dr. Bill Sanborn, has stepped down to pursue industry, to work at a local biotech company. This new venture that Bill Sanborn is engaging in is a spinoff from UC San Diego Technology, and it's a great opportunity, Bill, to stay in our community and to advance healthcare. Bill Sanborn will continue to practice at UC San Diego. So to get started, I'm going to introduce Tom Savides, who will introduce our panelists. Tom, please.
Thanks, David. Thanks for the introduction, and really thanks for all you've done to really help UCSD gastroenterology be #1 in the world in terms of research. And I just want to reflect. I am, I guess, for the third time being the interim chief, but the chief position here really sets up, who UCSD GI is and what we've done, what we've accomplished, not just for San Diego, but for the world. The division was created in 1968 when UCSD was founded. There were bright minds who came out from the NIH, from a lot of the Ivy League schools back east when they founded UCSD as a medical school and recruited in the best and the brightest at that time. The first GI chief then was Dr. Henry Wheeler, who came from Columbia, who was one of the world's experts in liver physiology research. He then subsequently became the first chief of Division of Internal Medicine here in UCSD. So he actually spanned many different parts of being here at UCSD. After this was John Eisenberg, who got recruited from UCLA. John was one of the world experts in the understanding the pathogenesis of peptic ulcer disease, and really because of a lot of the work he did led to understanding the impact of H. pylori and nonsteroidals in terms of creating ulcers, as well as developing drugs such as Pepcid and Prilosec, the H2 blockers and the PPI drugs, to help treat this. And so this was a disease, for those of you who are old enough to remember, that used to be managed surgically. Now nobody ever gets surgery for peptic ulcer disease. We manage it medically. A lot of that work came out of here in John Eisenberg. After John stepped down, Rick Bowen took over. Rick was recruited from the University of Michigan. He is one of the world's experts in hereditary colon cancer, specifically Lynch syndrome. And Rick really has been instrumental in our understanding about hereditary cancers, and also in founding the Cancer Center here. Rick also became a president of the American Gastroenterology Association during his career too. When Rick left to take an offer, to expand his research portfolio in Texas, we then were able to keep his protege, John Carruthers, who also was an expert in hereditary colon cancer, and many of you may know him from when he was here previously. John also is a superstar and now is the chair of medicine at University of Michigan as well, and really doing phenomenal things out there. And then finally, once John took the job at University of Michigan, we did a national search, and we're very lucky, and I think in a good part, thankful to Dr. Brenner to helping this, to recruit Bill Sanborn, who's one of the world's experts in inflammatory bowel disease, and especially in terms of clinical trials and management. And Bill has been here with us for nearly 10 years. He's still with us, but he's now, like many people at UCSD, has now gone on and taken what he's learned in academics, and it's going to be applying it in industry and creating a company that we hope will help many, many people throughout the world with what they're doing, and also become another success story for San Diego biotech community. So we're very excited about that. The reason I bring up the division chiefs is that these division chiefs really set the culture and bring in the people who are great. So they themselves then bring in outstanding faculty from either as fellows, as research fellows from NIH-funded T32 grants that we have, or they bring them in as junior faculty. And a number of the speakers that we have today really are, part of that model, which is why finding that person, is so critical to, what subsequently happens over the next, 5, 10, 20 years, a division chief's, tenure. And one of the great successes of this continual advancement in terms of our science and our researchers and our fellows that we bring in has been the formation of the NIH-funded San Diego Digestive Diseases Research Center. You'll hear it called SDDRC. And our first speaker, Bernd Schnabl, is one of the co-directors of this, and he'll be telling us a little bit more about it. The thematic focus of this is on inflammation of the digestive tract. And the investigators are looking at, looking at research in terms of how inflammation, immunity, and the microbiome affect both the GI tract and the liver. So it's incredibly impactful, not just from a basic science point of view, but also in terms of translation to clinical impact. We've seen, as we saw on the previous slide, getting the #1, the best global university for gastroenterology and hepatology in the world. This #1 ranking is really well deserved. I'm so proud of this, because when you really look at our division, the sheer brain power in terms of amazing scientists and amazing talent is not surpassed. #2 on this ranking, a distant #2, is Harvard. And then the rest, the next 3 after that, were from outside of the United States. So, really, it's something that I think we all should be quite proud about. And it's amazing to think that we can go from being a fledgling institution in 1968 to 53 years later being #1 in the world for research. So today it really is my pleasure to introduce 3 of our superstar faculty. These are our junior mid-level people who are really going to be setting precedent in the world for the research to come. And they only represent a small fraction of the 42 faculty that we have, 12 of whom have NIH funding. And many of them did come up through the NIH-funded T32 research fellowships that we have. So again, it's my pleasure to have everybody on the call today, and then also for these 3 to be able to share with us what they're doing. So for my first introduction, I'd like to introduce Dr. Bernd Schnabl. Bernd has been a longtime collaborator with Dr. Brenner. In fact, we thank Dr. Brenner for being able to help us recruit Bernd when he was a fellow with him at Columbia, and bring him and finish up on our T32 research here and develop really what's been just a fantastic research career, and also now co-director of the San Diego Digestive Disease Research Center. So with that, Bernd, I'm going to turn it over to you.
Hello, and thank you for joining. I would like to introduce the San Diego Digestive Diseases Research Center, or short SDDRC, and illustrate some of our recent scientific achievements. We are one of the few NIH-funded centers in the United States. We have 3 centers in California. One is in San Francisco, one in Los Angeles, and since 2019, we have now 1 in San Diego. We have currently 54 center members. Our home is the GI division. But our members are from an incredible range of disciplines, and our center wants to bridge across divisions, departments, schools, and even institutions. Our overarching goal is to create a community of researchers that is truly collaborative, that can generate novel hypotheses and make groundbreaking discoveries. Our scientific mission is to support basic translational and clinical research that will lead to improved treatment and prevention of diseases in the digestive system, including the liver and the pancreas. We oftentimes start with an observation in humans, and this is why our human translational core is so important. We further investigate this in preclinical models and then apply more sophisticated basic science technologies such as microbiomics and functional genomics to this finding. Once we made a discovery, we can then circle back to the bedside from the patients, and this can now be applied as a new treatment for disease. We have integrated 2 centers of our division into SDRC. One is the Inflammatory Bowel Disease Center, or short IBD Center, and the second center is a Non-Alcoholic Fatty Liver Disease Center, or NAFLD Center. In addition, we have a close collaboration with the ACTRI, or the Altman Clinic Translational Research Institute at UC San Diego. So in the following, I would like to introduce you to one of our major focuses of our center. And one of these main focuses is the gut microbiota, which consists of bacteria, fungi, and viruses. The vast majority of microbes is in the small and large intestine, and this is why, as a GI division, we are predestined to research the microbiome. If you look into the mirror, more than half of yourself are microbes, especially bacteria. In addition, we have far more microbial genes in our body than we in fact have human genes. As a team, we work together every day and investigate the microbiome in areas such as inflammatory bowel diseases, chronic liver diseases, pancreatic and esophageal diseases. And in the following, I want to give you 2 examples what we have done over the last couple of years. We know that patients with a certain disease have differences in their microbial composition in the intestine and in the stool as compared with healthy controls. And one of our center members, Dr. Lumba, has applied this to patients with non-alcoholic fatty liver disease. So he compared the bacterial signature in the stool from patients with non-alcoholic fatty liver disease at early stages, so in patients with fatty liver, and in patients with non-alcoholic fatty liver disease in late stages, which is called cirrhosis. And he was very successful discriminating patients with early versus advanced disease by using sophisticated microbial tools to analyze the stool microbiome. So this is a very good example how the microbiome can be used as a biomarker for disease. However, microbiome is not only a marker for disease, we now know that it also contributes to disease. And especially bacteria, we know, for example, in obese patients are very different as compared with bacteria in the intestine from non-obese subjects. And as evidence that these bacterial changes can contribute to disease, researchers over the last decade have transplanted stool from obese and non-obese patients into mice. They fed them the same diet, and very astonishingly, the mice that received stool from non-obese subjects remained lean, while the mice that received stool from obese subjects became in fact obese, indicating that it's not only the diet that somebody eats, but also the gut microbiome that contributes to obesity. And in the next following 2 slides, I want to show you some of our evidence, how we have linked gut microbiome, and especially a toxin, to liver disease, and in this case to alcohol-associated liver disease. So what we found was a bacterium which is called Enterococcus faecalis to produce a toxin called cytolysine. And when we looked into a patient cohort, you can see that our control population was essentially toxin negative. However, 30% of the patients with this severe liver disease, which is called alcoholic hepatitis, they were positive for this toxin in their stool. And when we looked at disease outcome, it was very clear that patients who did not have the toxin present had a very good survival rate, while most of the patients who were toxin positive eventually died within 180 days. So the question was for us, how can we get rid of these bacteria that produce the toxin? So we decided to treat this bacteria with the microbiome's own weapons, and these weapons are called bacteriophages. And in the following, I want to introduce you to phages and how they target bacteria in a short video.
The basic structure consists of a head, a sheath, and tail fibers. The tail fibers are what mediate attachment to the bacterial cell. The DNA stored in the head will then travel down the sheath and be injected inside the cell. Once inside the cell, the phage will hijack the cellular machinery to make many copies of itself. Lastly, the newly assembled phages burst forth from the bacterium, which resets their phage life cycle and kills the bacterium in the process.
So this is one of the most important parts, that phages are naturally occurring in our intestine. And now we can use them to target very specifically these bacteria. And the second advantage is that once these bacteria are killed, the progeny of these phages are released, and they can now infect and kill many other toxin-producing bacteria. And this is what we have done now in a preclinical model. So we have created these bacteriophages to kill essentially these toxin-producing bacteria. And in a preclinical model of liver disease, we were now able to show that once we use this very specific bacteriophages shown here in pink color, you get an improvement in liver disease. And most importantly, you can also reduce these toxin-producing bacteria, so suggesting that phage therapy could be applied, hopefully in the near future, to patients with alcoholic hepatitis and this very severe disease. At the end of this presentation, I would like to thank you for your attention. On this last slide, I have indicated how you can get in contact with us. We have a website, but you can also reach out via email.
Great. Thanks, Bernd. That was fantastic. Really like that, especially the video was fantastic too. So amazing work that you're doing. And hopefully during the question and answer period, we can hear more about that and maybe even more about phage therapy too. It's my pleasure now to introduce our next speaker, Dr. Rena Yadlapati. Dr. Yadlapati is really one of the up-and-coming superstars in the field of esophageal motility. She came to us, initially she had been at Northwestern, which is really one of the main centers in the country, if not the world, for esophageal motility issues and other things related to motility in the GI tract. Then was at Colorado for 2 years, and we were lucky to recruit her here to UCSD to join us. And Dr. Yadlapati is developing an amazing esophageal center here at UCSD, and I think that you all enjoy hearing what she's up to now in terms of her research. So thank you, Rena.
Thank you, Dr. Savides. I am really excited to share with all of you where we are in terms of crossroads with innovation and patient care for esophageal diseases, something that I'm very passionate about. And this includes esophageal reflux, Barrett's esophagus, and swallowing disorders. So, if we were to poll the audience today, how many of you in the past week have experienced symptoms such as heartburn, regurgitation, or difficulty swallowing? What the data would tell us is that at least half of you have had one of these symptoms in the past week. And actually, in the last year during the pandemic, this number has increased, where more patients are saying, I might have had some mild heartburn, but really it's become much more prominent now, whether it's from stress or lifestyle changes or what be it. Now, if we think about these patients that commonly experience symptoms, what is their typical journey today in the medical community? Well, let's think about Mr. Smith, who's had burning behind his sternum for the past 10 years. And more recently has been noticing that food is getting stuck in his food pipe or his esophagus. About 10 years ago, he tried acid blocking medications, started with Prilosec, switched over to Nexium, didn't really derive any improvement. Saw a gastroenterologist that did an endoscopy and reassured him that everything looked quite normal in the camera. So he went back on these medications, but then started hearing about some potential long-term risks of the medications and decided that he wanted to seek a second opinion. He again had another endoscopy, which was really not revealing. And then he was referred to a multitude of other specialists, underwent several tests. And here we are 10 years later, where Mr. Smith doesn't really have any diagnostic clarity as to what's causing his symptoms. The medications that he tried never really helped with the symptoms. And this has contributed to a tremendous amount of quality of life impairment, not to mention resource utilization. And also along the way, he's had an underlying fear that there might be esophageal cancer that's been missed. I specifically wanted to mention esophageal cancer because last month was Esophageal Cancer Awareness Month. And a big goal that we have is to really flatten the esophageal cancer curve. If you look at this figure down here, since the 1970s, the incidence of cancers have really reduced. We've done a great job in reducing the incidence of breast cancer, gastric cancer, lung cancer. But if you look at this blue line, this is esophageal cancer, and the incidence just continues to rise. This is a focus across the world and also in one of our research programs, which is the GEODE program that I co-direct with my colleagues, Dr. Shah and Dr. Curtius, and it focuses on gastric and esophageal cancer. So if we go back to the patient who's had heartburn or swallowing symptoms, and if they come to UC San Diego, how would their experience be different than what Mr. Smith experienced? So the focus at our center is to really reduce the burden on patients by providing high quality care that's personalized to the patient, by not only embracing, but leading the path in innovation, and then also training the future generation. So if you came to UC San Diego with these symptoms, you might enroll in a research study that we have, where you produce saliva into a tube, and that saliva is placed on this device, which is very similar to a pregnancy test strip. And within a few minutes, you'll have a test line compared to the control. And what it's measuring is multiple different biomarkers, including microbiome and different proteins that may be in the stomach. And if there's a high amount of them in the saliva, it may indicate that you're having a high burden of reflux. And this is from a study that we published recently where patients that were healthy and asymptomatic really had very low levels of pepsin, which is a protein secreted in the stomach. But when you look at patients with reflux, or even Barrett's esophagus and esophageal cancer, you can see that the concentration of this increases tremendously. So there's tremendous potential for this, what we call a spit test. Primary care physicians or general gastroenterologists could offer this to a patient before starting them on medications or before proceeding with more testing. Now, let's say you do need to have an upper endoscopy and you come to UC San Diego. Well, here, not only do we look with the camera, but during that same session while you're sedated, we might do more testing that's minimally invasive, doesn't add more risk, but provides more information about your esophageal health. So take, for instance, the functional lumen imaging probe. This is known as FLIP, and it's a technology that I was part of during my training when it was being developed. It's very near and dear to my heart. But it consists of a balloon that is placed in the esophagus, again, while you're sedated. And when it's filled up, the novel technology measures the contractions of the muscles in the esophagus. And so in real time, again, while you're sedated, we will see this image here that's dynamic. We'll get a 3D rendition of the esophagus. We can also appreciate that there would be contractions very nicely propagating from the mouth down to the stomach. Something else that we can do during the endoscopy is place a biosensor, small little capsule that's about the size of an eraser tip. And it sticks to the lower part of the esophagus and it measures acid. And it does this over 4 days while you're in your usual state of activities and health. And what we found in a recent clinical trial that we published in Gastroenterology is that the data we acquire from this biosensor is incredibly helpful in us understanding whether, this is a patient that may need to see surgery, that may need more medications, or this is a patient that really can get off of their acid blocking medication and we can focus their therapy on something else completely. Now, let's say, we do this testing at UC San Diego and everything is normal. Are we just going to say, well, so long, you don't need to see us. We don't know what the reason for your symptoms are? Absolutely not, because there is a heightened appreciation amongst the community and also at UCSD that nerve sensitivity, so the nerves in the esophagus, which are very superficial in the lining, can be hypersensitive, and patients that have hypersensitivity also tend to have a hypervigilance and awareness about their symptoms. And we have found that by promoting relaxation strategies or partnering with a psychologist to provide hypnotherapy can really break this cycle and make all the difference. So in summary, swallowing and reflux symptoms are incredibly prevalent. They're associated with a quality of life impairment and tremendous cost to our society. And I'm really proud that at UC San Diego, our Center for Esophageal Diseases is really leading innovation to streamline evaluation and personalized therapies for our patients. Thank you so much. I really look forward to the Q&A session today. Thanks.
Great. Thank you, Dr. Yadlapati. That was fantastic. And just a little, again, historic footnote, that device that she showed you that it was implanted in the esophagus that measures for a few days actually was developed here at UCSD as well with a local biotech company and eventually got sold to one of the major manufacturers. But I remember working on that and meeting at Starbucks trying to figure out how do we make this design a little bit better. So I'm glad to see it's, again, truly from a bench engineering perspective, then all the way into clinical practice use around the world. For my next introduction, I'm pleased to announce and introduce Dr. Parambir Dulai. Parambir has been really one of the great additions to UCSD with the Inflammatory Bowel Disease group. He was recruited here by Bill Sanborn. He was really one of the superstars, as we were looking for fellows to attract into our Research T32 program. He came to us from Dartmouth, where he was just unbelievable. And we wish he'd gone and become an interventional endoscopist, but he somehow saw the light and became an inflammatory bowel disease researcher, and probably better for the world doing that than the other stuff. But it's my pleasure to introduce Dr. Dulai.
Thanks so much, Tom, for that warm introduction. So I'll be talking today about some leading edge research and really how we've begun to think about integrating multiple different data sets to discover novel therapeutic solutions with IBD as an example, but also a roadmap for other conditions. So as a background, ulcerative colitis and Crohn's disease are inflammatory bowel diseases. These conditions are characterized by bloody diarrhea, weight loss, poor nutrition. And over time, these patients end up developing severe debilitating complications that ultimately require surgeries, hospitalization, supplemental nutrition. Despite our advances over the last 2 decades, current treatments are really only effective in a third of patients at best. And we often have to cycle back between multiple therapies, which have risks of infections, complications, and even cancer. What we do know, though, is that inflammatory bowel diseases are a complex interaction between the immune system and the microbes in our digestive tract. And so to get a really complete understanding of disease mechanisms, we have to apply a multi-level evaluation of not only what bacteria are there, but what are they producing, what are they metabolizing, and how are our own body's immune cells responding to that. So I'm going to walk through an example of that we've done here in IBD and how we plan to transform this approach to other conditions through the SDDRC. So a few years ago, as part of my research efforts, we began to prospectively recruit IBD patients into a biobank specifically for this purpose of doing multi-integrative omics analysis. We collected very detailed disease activity assessments with partial Mayo scores, endoscopic scores, and histology as well, in addition to markers of inflammation. We collected stool from these patients prior to their lower endoscopies. And just as a reference, all of these patients were already receiving standard of care therapies, so steroids, immunomodulators, and even expensive and risky biologic therapies. But some of them had persistent disease despite these. We started out by first wanting to do a very deep dive into the microbes. So we wanted to understand not only what bacteria were there through 16S and metagenomics, but what their metabolisms looks like with metabolomics, and then what they were producing and how those products were being digested through proteomics and peptidomics. And so this figure is an example of what we did. And you can see here, we started with a cohort of about 40 ulcerative colitis patients, but we quickly ramped up to include another over 200 patients that included Crohn's disease and healthy controls. We included patients who had a wide variety of disease severity to make sure it was representative of the entire patient population. And we had both stool and serum and blood from these patients. Now, I was not alone in this endeavor, and we actually partnered with major researchers across campus to try to get this done. We were able to partner with David Gonzalez's lab to do proteomics, with Rob Knight's lab to do metagenomics and 16S, and with Peter Dorstein's lab to do metabolomics. And for the first time ever in IBD, bring together such an in-depth data set to try to attempt to identify novel discoveries for treatment. What we were really surprised and pleased with was that we were actually able to identify a specific bacteria that was driving disease. Most notably, that bacteria that we identified was Bacteroides. This was a bacteria that was abundant in the stool for patients who had active disease and was associated with the presence of disease severity and ulcerative colitis. But it was the in-depth analysis of the metabolism and the peptides and the proteins that actually allowed us to identify the fact that there were some Bacteroides that overproduced certain peptides and proteases, and there were some Bacteroides that underproduced, suggesting that there were actually mutations in some of these Bacteroides, which we're currently genotyping, that led to them overproducing these enzymes that cause this inflammation and activity. Now, as Dr. Schnabl had alluded to earlier, one of the core philosophies within the SDDRC is to take some of these discoveries, use preclinical models, validate those, and then try to apply them in humans through novel strategies. So that's what we did next. What we also found was that about 40 to 45% of these ulcerative colitis patients were affected by these overproducers. We then actually took Bacteroides from these patients. So we took their stool, we cultured the bacteria, we identified these Bacteroides species and specifically pulled them out. And then we began doing experiments with those specific bacteria and biopsies taken from humans to understand what would happen if we tried to inhibit these bacteria or the proteases that they were producing. This first image you see here on the bottom right of your screen shows the epithelial layer or the colon biopsies with the Bacteroides, and you can see it's just a disarray of architecture. There's no sense or reason to it. But when we add in the inhibitor, where we specifically block these proteases that we found, you can see that there's very nice return of the architecture, circular cells, sort of repopulation of the tight junctions, and the integrity of these cells significantly improved. What we then wanted to do was further advance this observation and actually do these in preclinical mouse models. So we took germ-free mice that were available to us through collaborations through the SDDRC. We colonized them with stool from these same patients that we had sequenced, and we treated some of these mice with inhibitors of these proteases and some without. And so what you can see here on this bar plot is for the patients with these blue dots, for the patients who had stool with very low protease production. So despite the presence of these Bacteroides were not making proteases, they had very low colitis activity scores, regardless of whether we gave them an inhibitor or not. But for the patients who had Bacteroides that were overproducing these proteases and who were not treated with these protease inhibitors, their colitis activity scores were very high, significantly higher than the other groups. And we were able to reverse that damage with the inhibition cocktail and the drug therapies that we identified. We wanted to take this one step further, and rather than just putting the stool in, we actually took those Bacteroides that we cultured and put them alone in the mouse to see if we could recapture this. And again, we saw that in this dark red, the group with the patients who had Bacteroides only in their colon, these mice, they had very significantly higher colitis scores compared to when we treated them with a protease inhibitor. We were able to prevent the induction of this colitis and inflammation. So the totality of this and several other experiments that we did across the campus led to the identification that targeting Bacteroides proteases represented a novel personalized therapeutic target for ulcerative colitis patients who were not responding to conventional therapy. So this created an opportunity for us to think about whether we could identify these add-on therapies for patients to really optimize response to current agents. We've identified similar observations for Crohn's disease and plan to expand this across other conditions. But as I noted earlier, the microbes are just one side of the equation. We also have to think about how the host or how we respond to these microbes, which drives this disease. So in partner with John Chang's lab, we were actually able to do some very in-depth tissue level sequencing of the immune cells to understand what cells were there and what they were producing and how their gene expression profiles were changing. One of the biggest barriers to human immune cell studies is that we often have to rely on live cells, which means we have to go through complex processes to collect these samples, digest them, store them, and many of these cells are very difficult to work with. But with some novel imaging and sequencing approaches, which I showed you on the right of this screen, we're actually able to take frozen samples from these colonoscopies, stain them using novel sequencing and imaging approaches, and actually identify different cell types and sequence those specific cell types to understand how neutrophils respond to these bacteria, how T cells respond, macrophages, and even natural killer cells, which are often difficult to work with. And I think this integrative data set is what's going to allow us to really fully capture that host microbe response that we want to understand, not only in inflammatory bowel disease, but other situations as well, other conditions as well. So when we think about how we brought all this together, I mean, this is a massive undertaking across campus, and I don't think we would have been able to do this without the support of the SDDRC. And so our hope is that with this data set, we're going to be able to create a common repository that not only scientists across campus, but investigators across the country and collaborators in other industry fields can also work with us. By linking data HIPAA compliant resources with health records, patient disease outcomes, microbial composition, metabolism, immune profiles, and banked immune cells, we're hopeful that over time, as patients provide us their samples, we can sequence these samples, identify novel discoveries, and maybe even re-identify patients that would be most ideal for some of these novel interventions and novel therapeutics that we might identify. And so with that, I'd like to thank you for the time, and I'd like to specifically thank Dr. Schnabl, Dr. Ekman, the SDDRC, and Dr. Savides for the time here, and Dr. Brenner and Dr. Sanborn, who's stepped down, but for the vision of bringing this campus together and allowing us to benefit from the resources that have been available. Thank you.
There's a question about endoscopy and colonoscopy for screening, and I understand the colonoscopy. Maybe we should split it up. Maybe we should have Rena do the endoscopy for screening and have Tom do the colonoscopy for screening. so just a general principles for the group.
Okay, sure. The general principle is that, as we get older, our risk of getting colon cancer increases. So there's very good data showing that if you do some form of colon cancer screening, you can do an intervention. The intervention being you can do a colonoscopy, find a polyp, remove it, and then that polyp can never become a cancer. So really is a way to prevent colon cancer. We've been making great strides in this. Now, there's several different ways to do this. You don't have to get a colonoscopy. You can get a stool-based card that look for blood or DNA. They're called stool fit tests or Cologuards. You see them on TV. Those actually are pretty good too. And we want people to get some sort of screening. The age we usually start is around 50 years old. There's some data from the American Cancer Society, some recommendations saying maybe start at age 45, and African American population start at age 45. Not every organization is embracing age 45 yet, but around 50, is the time to start thinking about it. And then usually it's every 10 years in terms of some sort of screening. If it's colonoscopy, if you're doing the stool-based cards, it could be every year with FIT tests, every 3 years with Cologuards. And if you have a family member who had colon cancer, say the family member had colon cancer at age 55, usually you would start screening 10 years before that. And then the other issue is if you have any other underlying conditions that predispose to colon cancer, such as chronic ulcerative colitis or chronic Crohn's colitis, you're going to be at increased risk for colon cancer. Those recommendations going to be earlier, as well as if you're part of some familial syndromes in which you may want to get screened earlier. So those are the gist of things. So the main thing is, as Katie Couric once said, you don't want to die of embarrassment by not getting screened. It doesn't matter how you get screened, just get some sort of screening.
Rena, yeah.
Yeah, and then I can piggyback to speaking about esophageal cancer. So, this is very different than colon cancer because there are certain populations that are clearly at higher risk of esophageal cancer. For instance, the prevalence in women is much lower than in men. And for population health and risk reasons, the societies have determined that it's not realistic to screen every single patient for esophageal cancer, but there are more and more guidelines that are coming out saying that if you are a man over the age of 50 that has some risk factors, and these could be you've had 5 or more years of reflux symptoms, you have obesity, you're a smoker or a former smoker, or a family history of Barrett's esophagus or esophageal cancer, these are indications to screen for esophageal cancer. Right now, the screening is with an upper endoscopy, but there is a lot of excitement and innovation in this area. They're not readily available right now, but there are these new tests with strings and sponges that can be swallowed that can detect certain proteins and genomic profiles. And so that's something to keep an eye out for in the future.
Thank you. There are some questions for Parambir about, there's some confusion about the difference between irritable bowel syndrome and inflammatory bowel disease. So maybe just give us a little bit of background about that.
Yeah, so inflammatory bowel disease is a immunological response to the bacteria, which leads to inflammation and damage to the intestinal lining that can be visible, bleeding, complications, and it's progressive over time. Irritable bowel syndrome may also be a similar response to the bacteria, but it doesn't lead to the breakdown in the lining of the colon or the GI tract. It doesn't lead to ulcers, inflammation, need for surgery or hospitalization. And it's mostly a symptom-based condition, whereas inflammatory bowel disease can lead to structural damage and structural complications to the person's digestive tract.
Are they related that the same person can have them both, or are they completely?
And so that's the other condition, is that some people can actually have an overlap. And something I wasn't able to share in the slides was that we're beginning to identify some microbial overlaps that might account for certain IBS, irritable bowel syndrome type symptoms being present in inflammatory bowel disease and so forth.
Thanks. For Bernd, there are questions about probiotics. Where do probiotics stand now? Are they used, therapeutically or just in research?
Thank you. So usually, generally, as especially in the US, we have like 40 to 50% of the real fibers that we are eating generally are that we are supposed to eat, we are eating. So we are essentially eating not enough vegetables, not enough fruits. And that essentially changes the gut microbiota very dramatically and shifts it towards away from the good bacteria, more towards the the bad bacteria or the bacteria that can eventually do harm. So in general, probiotics are probably very helpful just to give good gut health or restore gut health. For certain diseases, there are indications to use probiotics, but most of the clinical trials, unfortunately, with the probiotics especially, they have not been reproduced with the same probiotics. Or other clinical trials have added vitamins or prebiotics to this cocktail of treatment. So currently, we have very few diseases where we definitively can recommend probiotics as a treatment and therapy.
Thank you. For Rena, there's questions that one of the people said, this sounds a lot like me, the patient you presented, and they get reflux with spicy foods. They want to know what to do.
That is a great question. And my quick answer would be, it really depends on so many factors. What we have learned in reflux is that not all patients are the same. And so, one patient might have a hiatal hernia. And so contents are staying in that part of the stomach that's above the diaphragm and refluxing up into the esophagus. Someone else might have weak muscles in the esophagus, and so everything is just sitting around in there, causing heartburn. Someone else might have a nerve hypersensitivity. So the bottom line is that there's not one answer for everyone, but we have tests that are readily available that can quickly figure it out.
Thank you. Here's another one. This is hot off the presses for Parambir. He's saying, Avali Cohen, I can acknowledge you said it. they want to know where did the bacteria come from in the first place. Are they from what you eat? Are they from stress? Is there some way of changing them? And does your lifestyle change them?
Yeah, so that's a great question. So these bacteria are there all the time. What we're beginning to realize, as I alluded to, was that some of them undergo a transformation to lead to the overproduction of some of these enzymes. And we've begun doing experiments and identified that changes in oxygen concentrations or certain medications result in these changes in these bacteria. And hopefully with that information, we'll be able to actually guide people on how they can change their lifestyle to actually prevent some of this from happening. And we've also begun to think about at-home tests, rapid tests that help detect some of these bacteria for you to know whether you're at risk for some of these complications.
Very good. Here's a question for Bernd. The question is you gave several examples of where the gut microbiome is involved with diseases. Are there other non-GI diseases? And one of the questions was about is the relationship between the gut microbiome with weight loss and weight gain? And since I have you, I'll give you another one. Is there a relationship with mental health? And they said, for example, anxiety and depression.
Yes. So psychiatry has now a new branch, which is called nutritional psychiatry. And exactly that's what they try to do, is essentially with nutrition, try to change the gut microbiome to essentially modulate it, because we know that the nerves in our GI tract are so highly communicating with the brain, and also the brain obviously communicates very much with the gut. So there's a lot of connections between gut health and anxiety and depression and Parkinson's disease. So I think there's a lot to discover. Now, how exactly they are mechanistically linked, what changes in the gut microbiome, what bacteria, what viruses, what fungi contribute to this, it's not always very well understood. But I think there's very good evidence that many of these microbial changes have an influence on mental diseases, like I have shown also for obesity, for example. That's another disease which is non-infectious, but the microbiome has a very important impact on the disease.
Yeah, very good. Since no one talked about this, I'm going to give this one to Tom. There are a couple questions about, Tom knows everything, so it's fair. There are a couple questions about intermittent fasting, daily fasting, and its effect on your overall health, and in particular on GI diseases like IBS.
Yeah, that is a tough one. So, it's the weight loss part is probably the important one. There have been some studies from UCSD suggesting 14 hours of fasting can, lead to significant weight loss. And that's one strategy people have been employing. It's actually interesting in that when they did that study, it didn't really matter what time of day that you did your 14 hours of the intermittent fasting. As composed to, there was a study that we did in the animal lab with Amir Zarampar from here, in which they looked at animals in whom you did feeding at nighttime versus daytime. And the animals who were fed at night gained significantly more weight than if you fed them during the daytime and fast them at night. So there's a difference. So there may be something with that, the 14-hour one. Clearly there's some data out of UCSD suggesting that. Whether or not that has an impact in terms of the IBS is kind of might, because one of the things you have to remember is that when we talk about the microbiome and people getting gas and bloating and discomfort, usually it's because food that you've eaten then goes through the GI tract and eventually goes, and there's bacteria either in the small bowel or the colon that then release gases, and then you have some of this distension and other symptoms. So people who aren't eating, they won't have the food go down and release the gases. So there may be some benefit of that as well.
There's a related question for Bernd also about IBS, and is there any relationship between IBS and your gut microflora? And is there any ideas about if you modified your gut microflora, could you possibly improve your IBS symptoms?
Yeah, I mean, IBS, is a broad spectrum. So I think, with IBS, some patients can have like bacterial overgrowth. A growth, so too many bacteria essentially in the small intestine, like Tom mentioned, and this can be associated with bloating, with more diarrhea episodes. So yes, so sometimes the bacteria can contribute to the disease by bacterial overgrowth, but also by producing this gas, which then also causes in patients with this hypersensitivity in their intestines, to have this discomfort and pain. And also if they have an IBS-related diarrhea, this also contributes to the diarrhea episodes.
Very good. A related question, but this is probably better for Parambir, is can you view, based on what you presented, could you view IBD as being caused by bacterial infection?
Yeah, so I think that's a very good thought, and I think that is definitely where we are beginning to head in our thinking, is that the microbes or the bacteria may be a trigger. And in somebody who's more likely to develop a certain immune response, those bacteria are what start that cascade, and then that cascade goes uncontrolled. And it goes back to some of the early observations that antibiotics are actually somewhat effective in certain patients for treating IBD, and maybe we should think about personalized antibiotics based on bacterial composition and function.
Very good. Here's one for Rena. Everyone likes your test, your saliva test. And they said, is there other tests that are relevant for GERD? So, for example, other blood tests relevant for GERD?
That's a great question. So no, there are no.
I'm sorry, GERD is gastrointestinal reflux. I got to be careful not to use it.
Absolutely, reflux. So there are no known serum or blood tests that can detect GERD, but like we mentioned, there are the saliva tests, and then there are ways to measure acid, and those are probably the two direct available tests right now.
Here's one we didn't mention. Is there any, this is from Eric Bernard, is there any relationship between the microbiome and arthritis? Either Bernd or Parambir can answer that or not. Arthritis.
Yeah, no, I think there actually is. We're, at least in our data sets, we're beginning to see some associations between certain microbes and what we call extra-intestinal manifestations, or joint pains and inflammatory bowel diseases. And in the rheumatoid arthritis literature and work, there's also been some association. So I think microbes can be blamed for everything, basically.
Okay. Then there are questions about several drugs that were near and dear to me in the past. People lost interest, like ranitidine, and you might want to mention why it was good and why it's no longer good, and also omeprazole. So maybe Rena can do that.
Yeah, absolutely. So ranitidine is an H2 blocker. Other ones in that family include cimetidine and famotidine. Those were one of the first acid blocking medications around for, as Tom was mentioning, peptic ulcer disease and also reflux. I think I saw a question in the chat. Ranitidine was FDA warning about a couple of years ago because there were some potential molecules that were identified in the packaging. There was no direct correlation with it, but the recommendation has been to not use ranitidine for the time being, and haven't heard updates on that. And then omeprazole is a proton pump inhibitor, or PPI. Other ones include dexlansoprazole or Dexilant, Prilosec, and there's many others. And this is a great medication for peptic ulcer disease and reflux when it's used in the right patient for the right indication. Over the last decade, there have been a number of studies that question whether there might be long-term risks of these PPI medications. Generally, the best done studies don't show a clear association, and causality has never been proven. So the recommendations, and this is coming out in our recent AGA best practices for GERD, is that PPIs are safe, but let's get them down to the lowest dose, lowest effective dose. And if you don't have a good reason to be on it, let's get you off of them.
Very good. So this is for Bernd. There are a couple questions about metformin. Metformin is believed by some people to be like a magical drug. That's good for whatever is wrong with you. Metformin will make it better. And in particular, the question from Jean-Pierre Malone is, can metformin play a role in the microbiome?
It's a very difficult question. David, you can actually probably help me to answer this question. I know that patients who are on metformin have a different compositional microbiome have a different microbiome composition. We know this for a very long time now, since many of the patients with type 2 diabetes are on metformin, and they have all been characterized, and we thought it's a signature from the disease, but it was not a signature from the disease, but it's essentially a signature from the metformin. Now, I don't know exactly, and I even don't know if it is known at all, how metformin affects the gut microbiome. Is it through, direct mechanisms on the bacteria, or whether it acts on the host, so on the human being, and then this affects the composition of the gut microbiome.
That's all I could think of. That if it improves autophagy, it might improve the cellular response to to bacteria, as you've shown that a lot of it is actually invagination and taking on the bacteria, the whole bacteria into the cell. So maybe I think we have time for, let's slip in one or two more if we go fast. There was a question also about I think it might be confusing about Zantac, ranitidine, and the different names. Could you just clarify that, because it is important that people understand what's going on.
Sure, absolutely. So the H2 receptor antagonist, that's a family of medications. They're not as effective as the PPIs. The ones that are included in that are ranitidine or Zantac, Pepcid or famotidine, and then cimetidine, and then the proton pump inhibitors. So I'll just say them very quickly. There's pantoprazole or Protonix, rabeprazole, also known as Esophagus, dexlansoprazole, known as Dexilant, omeprazole, I think we said lansoprazole, and then esomeprazole, which is Nexium, the purple pill.
Wow. Okay, you win. Here's a pretty sophisticated question for Parambir from Joan Lewis. That how are UC and Crohn's disease related, and can you distinguish them from their microbiome?
Yeah, no, that's a very thoughtful question. So what I'll do is I'll just give a brief sort of history on this. Crohn's disease and ulcerative colitis were given their names largely because of the way they presented. But when you go back in history, some of the early Crohn's disease patients actually presented very differently. And we didn't know until now that they were really Crohn's disease patients, but just not identified. So what we've begun to rethink is that we've traditionally thought of it as ulcerative colitis and Crohn's disease, but maybe there's 7 to 8 different subtypes. And those subtypes are really defined by the bacteria and the immune response. And so we're beginning to find observations that we can actually identify Crohn's colon involvement, similar to ulcerative colitis and some of these things. So I think we're going to rechange the classification based on what bacteria are there and what kind of immune cells are driving the inflammation.
This is an incredibly good conversation. Clearly, there's a lot more to be said than we get time to do it. This is a great discussion, and thank you, Tom, for hosting us.